Can go ahead again, please. Okay, the objective of my speech will be to update the audience on the COVID-19 and to communicate news of the PSMMC preparedness plan for these new diseases. First, I will start my talk about the environment samples in area in hospital where we have suspected unconfirmed case. Actually, and from China, this study showed the objective of this study was to determine the distribution of this SARS-CoV-2 in the hospital ward and in Wuhan and China by samplings air and surface. And the main results about this study showed that the virus was widely distributed in floors, in computers, in all surfaces in the hospitals, and also it was detected in air 4 meters from the patient. And the second main results of this study was that they confirmed that contamination was greater in intensive care unit than in general wards. That's why the authors advises to be more careful, to implement more the infection control, especially in area where there is critically ill patient or aerosol generating procedure like ICU. This in this slide showed the stability of the virus, the comparison between SARS-1 and SARS-CoV-2, and their stability in the surface. And as you know, this stability depends on temperature, in humidity. In general, the virus can persist in the surface, in my surface, 6 to 8 hours. Now I will, before to present our PSMMC preparedness plan, I will update you regarding some point related to our infection control plan. The first point is regarding the basic reproduction number, what we call R0. R0 is the expected number of cases directly generated by one case in a population where all individuals are susceptible to infection. And the R0 is proportional to the contact rate and will vary according to the local situation. In this recent review of 12 modeling studies, reports the mean basic reproductive number, R0 for COVID-19, it was almost 3.2. And as infection control, our major aim is to reduce this R0 to 1 or less than 1. And when the R0 became less than 1, that's meaning we can control the infection. The second point regarding the viral shedding. Over the course of infection, the virus has been identified in a respiratory tract specimen 1 to 2 days before the onset of symptoms. And it can persist for up to 8 days after the onset of symptoms in mild cases, and for a longer period in more severe cases, peaking in the second week after infection. The second study showed that the high viral load close to symptoms onset suggests that the SARS-CoV-2 can be easily transmissible at any early stage of infection. Regarding the infection in asymptomatic individuals, the asymptomatic infection at time of laboratory confirmation has been reported from many settings. Some of these cases developed some symptoms at a later stage of infection. And there are also reports of cases remaining asymptomatic throughout the whole duration of laboratory monitoring, which revealed viral RNA shedding in various sample types. In a recent modeling study, suggested that asymptomatic individuals might be a major driver for the growth of COVID-19 pandemic. And the authors conclude that it's unlikely that a pathogen can blanket the planet in 3 months with an R0 in approximately 3, as reported in the literature. In this manuscript shown in this slide, they present a mathematical model taking into account asymptomatic carriers, and their main results that an initial value of the effective reproduction numbers could range from 5.5 to 25%. That's meaning these asymptomatic patients, they have an R0 higher than the symptomatic patient. And as infection control, we need to focus our intervention on this group of patients. Regarding the transmission by the pre-symptomatic individuals, this pre-symptomatic transmission has been reported. Exposure in the cases occurred 1 to 3 days before the source patient developed symptoms. The pre-symptomatic transmission contributed at least to 48 and 62% of transmission in Singapore and China. Although transmission from asymptomatic patients has also been reported, the risk of transmission from pre-symptomatic or symptomatic patient is considered to be higher. The viral RNA is higher at the time of symptoms onset and decline after days of week. And finally, regarding the healthcare workers, of the confirmed cases in China, 3.8% were healthcare workers. That means 3.8% of all confirmed cases reported in China were healthcare workers. 15% of them presented severe forms. And the most important thing that in a report of 30 cases in healthcare workers, all cases had a history of direct contact. And when we say direct contact, that's meaning less than 1 meter with a confirmed COVID case, with an average number of contact between, an average is 12. And the average cumulative contact time is 1.5 to 2.7 hours. This data is very important for us infection control, where we will conduct the contact tracing and to classify our healthcare worker risk exposure. Regarding the transmission from mother to baby, now it's clear there is no vertical transmission. Transmission, it will be happened after delivery by a direct contact with between the baby and her mother. This slide summarizes the 4 scenarios of the COVID-19 infection. As you see here, 30% of patients are asymptomatic. And I think this group of patients represent the main dangerous population to spread the infection in the community and even in the hospital. And 55%, they have the 55%, sorry, 55%, they have mild or moderate symptoms. And in this group of patients, as you see, the mortality rate is it's 0. Regarding severe symptoms, the patient with severe symptoms represent only 10%, and the critical patient who required admission in ICU represent only 5%, but with a high mortality. This mortality now, it's clear that there is a big difference in the mortality rate between flu in the left and the COVID. Now it's clear that the COVID, it's 10 to 20 times more lethal than flu, especially in elderly patients with comorbidities. So, as infection control, we are face a virus which can be transmitted by droplet and contact. And this is the first time in the world that we have an outbreak, we have a pandemic with more than 2 million in three months. We have a virus who is severe and he is causing mortality, especially in elderly patients. And as you know, till now, there is no approved treatment, there is no vaccine. For all this reason, we consider this COVID-19 as a serious public health threat. For that reason, at PSMMC, we started to prepare a plan against this new emerging disease since more than 2 months. And the main compound of this plan was the administrative intervention, how to detect early all suspected cases in all entries in the hospital, and to establish a separate pathway for this group of patients. We need to implement a transmission precaution, the patient placement, patient transport, the personal protective equipment for healthcare workers, the environment cleaning, it's very important, and finally, how to manage the exposure to SARS-CoV-2 in the hospital, healthcare workers or patients. All this compound or this program is now in a policy which is published in our eGov portal. In green, I will focus especially in the compound with green because there is an update. And I will start by the early detection on confirmed case. Now, in all the entries of the hospital, in ER, in dialysis, in all the building, we implemented a visual triage team with a trained EMT or trained nurses. This team they are using a visual triage checklist. For any patient coming to the hospital, they will ask some epidemiological question and some clinical question, and for each response there is a score, and when the score is more than 4, the patient is considered as a high risk. The weakness of this 4 that it cannot discover patients who are asymptomatic or patient with a mild sign like sore throat or others. Then the patient will be assessed by the physician, and the assessment of the patient, the physician will assess the patient to decide if he will do nasopharyngeal swab or no. And the indication of this exam depends on the case definition. This case definition, it's dynamic. I think it was changed at least 2 or 3 times, and I'm sure it will be changed in the future, because now the clinical spectrum of the infection is very broad. It's not only respiratory symptoms with fever. Many other signs like conjunctivitis, like skin eruption, like cardiovascular manifestation are reported in literature. But now, until now, MOH, we are using the MOH and Saudi CDC case definition. There is a clinical presentation. That means the patient has fever with or respiratory symptoms, and epidemiologic link. Actually, the epidemiologic link is not very important for us because Riyadh is considered as an endemic area. When we have patient with a score more than 4, the EMT or nurse will provide him a surgical mask, and he will educate him how to wear the mask and ask him to perform hand hygiene, and then he will be admitted in a specific area. Those who come to ER, they are directly guided and admitted in 3rd, 4th, and 5th floor in building 9. For the other, for the inpatient, I have a slide to show you where we should admit the suspected case. Those who come to ER and they are critically ill, they should be managed in a resuscitation room with HEPA filter, and we need to implement airborne and contact precaution in this area because this is critically ill patient, and all staff who manage this case should wear a fit-tested N95 or PAPR. What I advise, well, this is strictly contraindicated to take specimen in this resuscitation area. This is the algorithm regarding the pathway of the suspected cases in our hospital. For example, for adult, if you have inpatient suspected to have COVID, we need to ask to call the ID on call to check if the patient fulfill the criteria of the case definition. If yes, if the patient is stable and he share a multi-bedded room in the ward, he should be transferred to the building 11 in the 5th floor. In case of a chronic patient or a vented patient in multi-bedded room, they should be transferred to the building 8 in the ground floor. And those who are critically unstable patients, they should be transferred directly to ICU. Then the primary physician, his responsibility to not to fulfill the notification form, it should be sent to preventive medicine. Then from preventive medicine, we will get the Hassan number. And at that time, we can send the nasopharyngeal swab or another swab to our laboratory with Hassan number. For the pediatric population, it will be the same thing. Call the ID pediatric on call to check. Then if the patient is stable in multi-bedded rooms, he should be transferred to the ward 4-1. And if not, if he is critically unstable or he needs ICU admission, should admit him in ICU. Now, regarding the precaution, the transmission precaution, we know that in infection control we have 4 types of precaution. We have the standard precaution. The standard precaution should be implemented for all patients coming to the hospital, suspected and confirmed, both or non-suspected. Then we have 3 modes or 3 types of precaution according to the mode of transmission. If the mode of transmission is contact, like MDRO, MRSA, Pseudomonas, it will be contact precaution. If the mode of transmission is droplet, it will be like influenza, it will be droplet precaution. And if the mode of transmission by aerosol, by airborne, we call this is the airborne precaution, like TB and measles. And in our now for COVID-19, we need to classify the patient in 2 categories. Patients who are stable and there is no aerosol generating procedure expected. In this group of patients, we need to implement contact precaution with droplet precaution. And when I said contact precaution, that's meaning we had to start by hand hygiene, then we need gown and gloves as PPEs. And for the droplet precaution, we need the surgical mask. The second categories is when patient he is unstable or the patient required an aerosol generating procedure. In this group of patients, they need a contact precaution, but instead of droplet precaution, it will be airborne precaution. And here, the only difference between the second group, the N95. In the stable patient, we need surgical mask. For the unstable patient, we need fitted N95 or PAPR. I forget to add that another PPEs needed for both groups. This is the face shield. Here we prepared some poster, and you can consult all this poster and all document in the eGov portal awareness COVID-19 in our electronic system. For example, for visual triage, we need standard precaution. The EMT or the nurse will wear a surgical mask, and the patient will wear the same thing, surgical mask. For example, in critically ill patient during aerosol procedure, airborne and contact, and for stable and aerosol generated procedure, it will be contact and droplet. Here, this is, you can consult this poster in our eGov portal. Hand hygiene, it's the main action to protect ourselves. Just to remind you that the 5 moments of hand hygiene should be now it should be done many times per day, not only in these 5 moments. And the most important thing, the proper technique of the hand hygiene. And as you know, for hand hygiene, there is 2 types. That we have the hand rub with alcohol and the hand washing. The hand rub should be at least 20 to 30 seconds, and the hand wash it will be more 30 to 1 minute. Now, regarding the contact precaution, as I told you, we need to have gloves and gown. For the droplet precaution, only surgical mask. And for the airborne, we need the fitted N95 mask. And for those who are with burn, they should wear the poppers. The most important thing here is we need to know how to wear, how to remove all the PPEs. And this is what we are doing as infection control. We are educating our staff regarding the donning, how to wear, and especially how to remove. How to wear, we should start usually by hand hygiene, then gown, mask or respirator, the face shield, and the last one is the gloves. And the most important thing, in my opinion, we need to be careful regarding the doffing, because the PPEs are contaminated, not like the donning. The donning, the PPEs, it's clean. There is no problem if we did some mistakes. But when we will remove our PPEs, the PPEs will be contaminated. We should first remove gloves, because they are the most dirty, and the gloves should be removed inside the room. Then goggles, gown, all these gloves, goggles and gown should be removed inside the room, and keep the mask of the respirator outside the room, because there is risk of to be contaminated when we can inhale contaminated air inside the room. Actually, and since I think 2 weeks, and according to MOH, to the Saudi CDC, we implemented universal masking in the hospital. And this universal masking, it's the aim is to protect patients and healthcare workers from exposure to infection from asymptomatic COVID-infected healthcare workers, and to protect the healthcare workers carrying undiagnosed asymptomatic COVID-19. This is the main rationale for the universal masking. A single mask can be worn across different cases and between cares of different patients. When providing care to a patient with a known or suspected COVID-19, the mask should be removed and wear a new one after hand hygiene. This mask must be changed if they became wet or contaminated, and the surgical mask, it's not allowed to be worn outside the clinical care area. It's not allowed to be hanged around the neck or kept in pocket, because you can infect yourself by this bad behavior and attitude. Regarding the process, how to use and to discard the surgical mask, a surgical face mask will be used at the start of each shift. For those individuals working in the clinical care unit, mask will be available at each entrance to the unit and will be used throughout the shift. In the event that the mask became visibly soiled, wet, or damaged, a new mask must be used. At the end of the shift, the healthcare workers will be asked to doff their face mask as they exit the unit. Now I will move to the last point regarding how to manage the healthcare workers who had contacts with patients with COVID-19 infection. When there is a healthcare worker exposure to a confirmed case, we need to know as infection control some data. First, if the confirmed case he is masked or unmasked. And if the confirmed case with him, I have contact, he was protected with mask or non-protected. The second criteria, I need to know if the healthcare workers wear surgical mask or respiratory, yes or no. And the timing for the contact, prolonged contact is in our hospital, in our policy, we consider a prolonged contact when it's more than 20 minutes, and the close contact when it's less than 1.5 meters. According to this criteria, I will have two categories. Category one, this is the prolonged close contact. That's meaning less than 1.5 meter of distance and more than 20 minutes with an asymptomatic confirmed COVID-19 patient or symptomatic confirmed patient wearing a face mask. This is the first scenario, the first category. In this group of patients, we have two risk exposure. It can be medium or low. Medium, when the healthcare worker, he did not wear PPEs or he did not wear a face mask. In this group of healthcare workers, we need an active surveillance for 14 days. That's meaning as infection control, we will call the patient daily and we will ask if he has fever or respiratory symptoms, and we will take swab and he will be excluded from work. The second group with low risk, for example, not wearing a protection or not wearing gown or gloves, this group, there is no indication to do swab. They continue their work and with self-delegated supervision. The second scenario, the second category, we have a prolonged close contact with confirmed case. He did not wearing a face mask. In this group, in this second category, we identify three exposure risks: high, medium, and low, according to the PPE wear by the healthcare workers. And as you know, as you see here, for the high and the medium exposure risk, we need an active surveillance. We need to take swab, and they will be restricted from work for 14 days. Those who are with low risk, it will be no indication for swab, just this is a self monitoring. And I think with this new guidelines from CDC, it will simplify our work as infection control, because we have difficulties to do the tracing contact list and to prepare this tracing contact list and to send to preventive medicine. In general, the healthcare workers, they are panic, and in the contact tracing, we found sometimes more than 50 and 60 healthcare workers. And as I showed before in China, the mean contact will be between 12 to 15 healthcare workers in China. Regarding the environment cleaning and disinfection, as the infection is transmitted by direct contact, it's very important to clean and to disinfect the environment and all the surface and the medical equipment. The inpatient room should be cleaned and disinfected at least daily. More frequent cleaning and disinfection for the high touch surfaces and following aerosol producing procedure. And we need to use approved MOH approved disinfectant, for example, hydrogen peroxide or the quaternarium ammonium or hypochlorite. Don't forget to the medical equipment. It's better to designate the medical equipment for each patient, but if we share the medical equipment, it should be cleaned and disinfected between after use. And the terminal cleaning should be done usually manual, and if we have the possibility with ultraviolet or hydrogen peroxide, it will be better. Here, just for the staff, because sometimes they ask us for some specialty they haven't the skills to perform the nasopharyngeal swab. Now it's easy. Use the flexible fine shifted aluminum swab. Insert the swab into the nostril and back to the nasopharynx and leave in place for 7 to 10 seconds. Slowly withdraw swab with a rotating motion and finally place tip of the swab into the vial container and send to the lab. Usually we are called from other department, asked us which the best, most sensitive swab should be collected for the diagnosis. Now it's clear. If your patient he is stable, he is not on mechanical ventilation, the best swab is the nasopharyngeal swab. And if your patient he is coughing with producing sputum, sputum has a good sensitivity. For patients who are under mechanical ventilation, we should send a deeply respiratory swab like bronchoalveolar or tracheal aspiration samples. Here, the algorithm of our hospital, how to dealing with suspected case. When we have suspected case, he will come to the ER. We will take nasopharyngeal swab. If the patient is clinically stable, he will go home and we will contact him after the result. If the result is positive and the patient is stable, he will be isolated in housing. If the patient he need admission, we will admit the patient in our hospital according to according to the severity. Now, when to discontinue the isolation, when we have confirmed case, it depends. We are dealing with symptomatic patient or asymptomatic patient. For those who are asymptomatic, we need to repeat the swab after 3 to 4 days. And to discontinue the isolation, we need at least 2 negative PCR than 24 hours interval. For those patients who are symptomatic, we need to wait until the patient will be recovered. 48 hours after recovery, we will start to repeat the PCR. If the first PCR is positive, we will wait 3 days to repeat the second one. And we decide to stop the isolation when we have 2 consecutive PCR 24 hours between. To conclude, I chose to conclude that the most important thing for this COVID-19, we need droplet and contact for stable patient, airborne and contact for unstable or hallucinogenic procedure. What we expect in the future, we don't know, but we have to prepare ourselves that we will see more patients. I think we need to update our plan by should we screen more patients in ER, especially, for example, why not all inpatient? So since we haven't a huge number of inpatient now, or only patient with a high risk, what is the role of the new rapid test in our PSMMC preparedness plan? We need to think from now for the strategy for personal protective equipment shortage. This problem is worldwide, and I think we need to prepare our policy. What about the extended use or the reuse of the N95 mask? I think this is I finish now, and thank you for your attention.
Thank you, Dr. Naoufel. We will open the questions and answer, and the floor is
huh?
I hope we don't have that echo again.
طيب الصوت ليس واضح. Cannot hear you. Cannot hear. It should be okay now. طيب no voice. It's no echo. Huh? I am looking for the question. There is no question, Dr. Zaidi.
Are we having plans or rules for residents who are seeing COVID-19 or supervising them sometime they don't know actually to handle these patients? Are we having plans or rules for residents who are seeing COVID-19?
يعني our plan is applicable for all healthcare workers. There is no specific plan for those who manage the COVID-19 patient. What we ask them, we advise them to be more careful regarding the infection control measure. It should be fully implemented. But there is no specific plan for those group of healthcare workers. I don't know if Dr. Abdurrahman he wants to add some other remarks or comments.
As Dr. Naoufel mentioned, the residents are healthcare workers. Actually, they are on the front line, very important part of the health worker, the residents. So they have to be aware, as like other healthcare worker, about the preparedness plan, like the visual triage, the pathway. They have to know the case definition. They have to know also how to take a swab and how to isolate those patients and all the measures of infection control with regard to those patients, as well as the modality of treatment, which is under clinical trial also. It's important for the resident, from senior to junior resident, is important part. And as infection control and our colleagues in infectious disease and other teams are willing to help those residents, and anyone has questions or concern, you can communicate with us at any time.
How can we dispose fresh cytology samples that are positive for COVID-19?
What?
How can we dispose fresh cytology samples that are positive for COVID-19?
We have policy for the waste management, and especially the infectious waste management. We have to follow the same policy. There is a specific container for this type of waste in the laboratory, and there is no specific precaution. This is like MERS-CoV precaution, like all infectious waste precaution.
Why are medical staff not obliged to wear masks while in the hospital?
No, it's since 2 weeks the universal masking, it's mandatory for all healthcare workers when they are inside the ward. Outside there is no indication, but now it's mandatory. All healthcare workers should wear surgical mask.
We are in the phase of universal masking now. All healthcare workers should wear a mask as per the MOH and MSD regulations and instructions.
The other question, why all patients with COVID-19 or not COVID-19 not obliged to wear masks while outside isolation areas? Why the patients are not supposed to use the masks?
We advise that the COVID patient, when he is inside his room and alone, no need to wear mask. But if as a healthcare worker, I will enter and I will manage the patient, I will ask him to wear a surgical mask, because I don't know, maybe during my management, maybe he can sneeze, he can cough, we should contain his aerosol. And in our policy, in our protocol, patient, COVID-19 suspected or confirmed patient, inside the room, no need to wear the mask, except if there is another healthcare workers in the room.
Can healthcare worker do swab to patient to a normal room only with HEPA filtration machine?
The best practice is to perform nasopharyngeal swab in a negative pressure room. But unfortunately, and this is very small memo from MOH and Saudi CDC, if there is no possibility for negative pressure room, we can take the swab in single room with a portable HEPA filter. And the most important thing is not the negative pressure room, or the most important thing that the person who will take the swab, he should wear N95, fitted N95 or PUPper with the other PPEs. But we can take the swab in single room with HEPA filter with full PPEs.
Some suggestions is about the resident, but what about the screening patients, the healthcare workers for COVID-19?
I think we will come to this phase. Until now, we are not screening. We are screening patients who we suspected, but we haven't till now a strategy to screen all healthcare workers or all patients. I don't know, maybe in the future, maybe we can discuss with the administration, with the MOH, if we need to screen all admitted patients and all healthcare workers. This should be discussed with the COVID committee task force.
I think now the MOH they are starting the mass screening. MOH, they started by the workers, the workers in healthcare setting. I think that the next phase will be also the healthcare worker. I think that there is a mass screening now by MOH through the different districts, through the worker, different areas. And now I think we'll reach the mass screening for the healthcare worker, because they are very important part of the population. And if we find the healthcare worker is positive, even he is asymptomatic or symptomatic, this is very important to prevent the transmission of disease to the other staff and to the community also. They are very important part of the mass screening, and I think we will reach a phase to do the mass screening for those kind of people.
The next question is surgical mask enough?
Yes, surgical mask enough in situation or when the patient is stable. And it's enough. And there is many study showed that the mode of transmission of COVID now, it's a droplet. It's not airborne. There is a lot of study for this. And when the patient is stable, surgical mask, it's enough. In situation of the patient is unstable or for aerosol genetic procedure, we should wear the N95 mask.
Another question is, do you think there is any infections going from patients after diseased patients, and during the process of preparing the body, do you expect there is a cross infection?
After death, all the fluid, the body fluid are infected, and we should deal with this group, with this COVID dead patient like MERS-CoV, and we should take our precaution, full precaution, contact and droplet precaution.
And there is a clear guideline from MOH CDC regarding those patients after their death and during the management, in the mortuary. There's a clear guideline from which, in details, you can find it in the CDC, MOH CDC Wakaya website.
And Sharia fatwa also, because there's somebody who's asking about Sharia fatwa, whether to prepare the disease or not. I think it's not our part, but there is definitely an answer in the sites responsible for that. A question from Dr. Fauja. What is the advice for protected code stroke? Is it for all or us, their satisfaction current follow?
Like I think, like the code blue, we need to minimize at least the contact of patient who respond to this code, and those who will manage patient with the stroke, they should wear their full PPEs. But this, I think we have the same problem with code blue, and we find that there is a lot of unnecessary people around the patient. Maybe it will be the same thing with the stroke. We should minimize the minimum of staff, and those who will deal and who will manage the patient, they should be well protected. Especially that COVID, we found that recently in literature, COVID, it can be an etiology of stroke.
The next question is when and where most of the healthcare workers wear the yellow gown, because some of them are wearing even if they are in the clinic. It's good, a good question.
No, it's clear. The PPEs, the mask should be wear inside in all the wards and even in the clinics. But the gloves, it's only when we have contact with patient. If there is no contact with patient, hand hygiene, frequent hand hygiene, it's enough.
What about someone had regular normal cold symptoms? Should he screen while he is at home with no history of contact with patients?
Actually, as if he is healthcare workers, we are screening this group of patients. And for the healthcare workers, even if they have a fever or they have sneeze, upper respiratory infection, we are screening them. For the other, we need the screening depend on the case definition. And till now, we are following the MOH guidelines. If he fulfill the criteria of the case definition, sure, we will screen him.
And if any patient from Riyadh and he has flu symptoms, you should call 937 and they will direct him according to his symptoms and his contact.
I got back asked for confirmation from Dr. Walid if you can mention for this directed to Dr. Walid Fauja. So we can change our protected code stroke to off, not to follow satisfaction. Please confirm. Can you please answer this? And you mentioned this for Dr. Fauja.
And I don't understand exactly what he needs. He said what?
Walid Fauja from neurology or senior staff. He was asking before advice protection code stroke. Is it for all or as per satisfaction, which is currently valid? And now you answered, but he asked to confirm again whether we change our protected stroke code or not. You want confirmation?
I think you are discussing this in COVID task force regarding this. Maybe Dr. Abdul Rahman, he is better.
I mean, Dr. Khoja, we should apply as we apply for the code blue, it should be applied for the stroke code. It's the same principle. We can discuss it with the administration and apply the same rules.
Okay, this is Dr. Mahir Jadid. Could you please give some advice after working hours and when entering their homes? What is your advice for the staff and healthcare workers before they go back home?
before to return back, it's better to keep all your clothes in the hospital with frequent hand hygiene, and there is no other specific rules.
I think we are done. So if you can close from your side because my mic is making it echo. Yes, please.
By this time, we can conclude our presentation. I would like to thank you all, and I would like to thank Dr. Naoufel for his excellent presentation, and also I would like to thank Dr. Zaidi and Continuous Education for giving us the opportunity for this excellent educational material. Thank you very much.
Thank you.